Hello, everyone. My name is Caitlin Bavis-Lasky, and I'm the Manager of Patient Programs, Research, and Advocacy at Lymphoma Canada. I'm pleased to welcome you all to today's educational session on T Cell Lymphomas. We appreciate all of you who have been able to join us live today to learn more about the disease-specific biology of T Cell lymphomas, and we'll examine the current Canadian treatment options available. This presentation will further highlight some treatments coming to Canada, as well as the research and results behind new therapies in clinical trials. Now, before I go ahead and introduce today's speaker, I would like to provide a bit of guidance about the Zoom software. This virtual software does not allow for you to share your video or your microphone. So if you do have a question, please save it for the non-Hodgkin lymphoma question and answer session following this breakout presentation. You can then ask your questions to the presenters live. I would like to go ahead and now introduce and welcome our speaker today, Dr. Rupesh Kansara. Dr. Kansara is a hematologist at Cancer Care Manitoba, specializing in lymphoproliferative and general hematology. He is also an assistant professor and program director for the hematology subspecialty training at the University of Manitoba. We thank you very much for joining us today to speak on this lymphoma subtype. Now I'd like to turn over the presentation to you, Dr. Kansara. Thank you, and take it away.
All right, thank you. I would like to thank Lymphoma Canada for this opportunity to present today. I am going to be talking about T cell lymphomas. Now, before I begin my presentation, this is my disclosure slide, and I do not have any conflict of interest with any of the regimens that I'm going to be talking about today in my presentation. So T cell lymphomas is a very broad topic. So I came up with a few objectives that I hope to cover during this session. So at the end of session, I'm hoping that the participants will be able to classify T cell lymphomas, understand the diagnosis of T cell lymphoma, appreciate how we stage different types of T cell lymphomas, and last but not the least, dwell a lot on understanding the treatments that we offer patients with T cell lymphoma, as well as some novel therapies that might become useful sometimes in the future. So before we begin to know about lymphoma, it is always important to know about basics and where do lymphoma come from. So essentially, everyone has a hematopoietic system, which consists of our blood cells. Our blood cells are made through our bone marrow initially. And as you may already know, there are different types of blood cells. We have red blood cells, we have white blood cells, and we have platelets. Now, of the white blood cells, we have these specific cells that we call lymphocytes. So our lymphocyte precursors, they actually originate in our bone marrow, and some lymphocytes become what we call B cell lymphomas, or I would say B lymphocytes, and some of these lymphocytes become T lymphocytes. Both B and T are part of our immune system. And what they do is they circulate in our lymphatic system. So our lymphatic system is composed of what we call lymph glands or lymph nodes and lymphatic vessels. And as you see in this diagram, there are a variety of areas in our body where we find these lymph glands. So we have lymph glands in the neck, we have lymph glands in the axilla or armpits, we have lymph nodes in the groin. We also have a lot of lymph glands within our abdomen, as well as in our mediastinum, which is in the area of the chest. If I were to take a lymph node and slice it into half, it looks like a kidney bean, and it has a specialized structure. And as you see, there are these vessels that bring your lymphocytes along with any antigen that your body might have been exposed to, which then triggers an immune response. And these are the vessels through which some of these lymphocytes leave. Now, it is important to know that lymphocytes, just like any other cell in our body, can become cancerous, and this is what we call lymphoma. So lymphoma is essentially a malignancy of your lymphocytes, and it is a very broad term, and we broadly divide our lymphomas into what we call non-Hodgkin's and Hodgkin's. And of the non-Hodgkin's, we have further divided these lymphocytes lymphoma into B cell lymphomas and T cell lymphomas. Now, B cell lymphomas account for about 85% of all cases of non-Hodgkin's lymphoma, whereas T cell lymphoma only account for about 15%. So T cell lymphomas are quite rare in comparison to B cell lymphomas. Now, there are several types of T cell lymphomas. And as you see, this list is quite exhaustive. There are approximately about 28 types of T cell lymphomas, and this list continues to increase as we identify more and more entities. Now, you may be wondering, how do we come up with diagnosis of T cell lymphoma, and how do we classify these diseases? So what is important for us to know is that cancer diagnosis requires a tissue sample, and the tissue that we get is the abnormal tissue at presentation. So for example, when patients present with enlarged lymph glands, we like to get tissue samples of those lymph nodes so that we can do our assessments. When patients come with a skin rash or skin lesions, then we biopsy these skin lesions. So what typically happens is, once we attain these tissue, they are sent to hematopathology, where they first look at how this tissue looks like, whether these are composed of abnormal cells or whether these are composed of normal cells. And if abnormal cells are found and the hematopathologist suspects that we are dealing with some sort of a hematologic malignancy, then they may use some specialized techniques to try to classify and sort out the final diagnosis. We may use some specific technologies like immunostain. So this is where we stain our cancer cells with certain antibodies, and these antibodies will be picked up based on some of the antigens that might be present on the cancer cells. We also use other technology like flow cytometry, again trying to identify antigens that are present on the surface of these cancer cells. We may use other sophisticated molecular technologies like T cell gene rearrangements, and sometimes we also use chromosome analysis, what we call cytogenetics, as well as other advanced technology such as FISH, or fluorescent in situ hybridization. And more recently, we have some even more advanced technologies such as gene expression signatures. What that means is we are trying to identify gene signatures that can be associated with different type of T cell lymphoma. So for example, in this panel, you can see that angioimmunoblastic T cell lymphoma has a certain signature, but that signature is completely different in patients with anaplastic large cell lymphoma, etc. Now, these technologies are very important for us to be able to sort out one lymphoma versus another, because that will determine how we treat our patients. Now, let us try to classify our T cell lymphomas. As you know from the previous slides, that there are about 28 different types. So how do we classify all of them? And the bottom line is we classify based on area where the lymphoma presents, as well as what is the nature of the disease, whether it is a slow-growing disease or a fast-growing disease. So for example, there are 4 groups here. So we have what we call a cutaneous group. So these are type of T cell lymphomas that pretty much present within your skin. So these include types like mycosis fungoides, or Sézary syndrome, or primary cutaneous CD30 positive T cell disorders, etc. Then there are some T cell lymphomas that specifically just affect your nodes or lymph glands. So these are things like peripheral T cell lymphoma, anaplastic large cell lymphoma, or angioimmunoblastic T cell lymphoma. There are other types that are not in the skin, not in the node, but they affect what we call extranodal tissue, meaning it is not involving the node. So things like NK/T cell lymphoma, we have enteropathy associated T cell lymphoma, which affects our bowels. We have hepatosplenic T cell lymphoma, which affects our liver as well as spleen. We then have a leukemic version of T cell lymphoma, where we see these circulating abnormal T cells. So things like adult T cell lymphoma / leukemia, or aggressive NK cell leukemia, T cell prolymphocytic leukemia, and etc. And I, in particular, like these adaptation of classification because the gray means that these are very fast growing and aggressive, meaning treatment is needed sooner rather than later, without which the outcome could be affected. Whereas the white ones are the slow growing ones, where treatment may not be as urgent, or if we do treatment, it may be localized therapy such as radiation. Now, let us look at what are the most common type of lymphoma. So this study was actually published in 2008, looking at the incidence of different type of T cell lymphomas. And what we found is that almost 60% of T cell lymphoma include peripheral T cell lymphoma, followed by angioimmunoblastic T cell lymphoma, or AITL, followed by anaplastic large cell lymphoma, which we call ALCL. So these three entities are the most common ones, and then the rest are quite rare. And from this study, we learned a couple of important lessons. So for example, we know that in North America, the peripheral T-cell lymphoma, or PTCL, is the most common one. But if you look at Asia, PTCL, even though it's common, it is not the commonest, where as ATLL is very common in Asia. We also noticed that different type of T-cell lymphoma present at different median age. So for example, the PTCL is more common in patients in their 60s, but if you look at aggressive lymphomas like hepatosplenic down right here, the median age is around 34, etc. So all of these lymphomas are quite different. Now, what do we do once we make a diagnosis of T-cell lymphoma? So I will discuss the staging of cutaneous lymphoma a little bit later, but here I'm talking about the staging of nodal or extranodal T-cell lymphomas. And what we do is we get CT scans, so CT scan of your neck, chest, abdomen, pelvis, as well as PET scan. Sometimes we may even consider doing bone marrow biopsy to make sure there is no lymphoma within the bone marrow. So stages are 4 stages. The first stage is where we find lymph node in just one part of the body on one side of the diaphragm. Stage 2 is where we see 2 or more groups of lymph nodes, but it is on one side of the diaphragm, which is a muscle that separates our abdomen and chest. Stage 3 is where we have lymph nodes on either side of the diaphragm. And stage 4 is when we have organ involvement. Now, in contrast to the nodal / extranodal T-cell lymphoma, the staging of skin lymphoma is done a little bit differently. So, for example, we look at the skin itself and see if the skin is involved with patches, which are these flat areas, or is there plaques which are slightly raised, or are there tumors? And if that is all sorted. We then also look for lymph node involvement. In addition to the skin involvement, we also look for any organ involvement. We also look for blood involvement. So the staging of cutaneous T-cell lymphoma is slightly different than the one that we do for the nodal groups or the extranodal groups. Now, with that background, perhaps we can now talk a little bit about treatment of T-cell lymphomas. Now, you already know by now that there are different types of T-cell lymphomas. So whenever, as a specialist, I'm planning treatment for T-cell lymphoma, the first question I ask is, what type of T-cell lymphoma am I dealing with? And whether that type of T-cell lymphoma is aggressive or slow growing, and what is the stage of that disease. I also look at the prognosis of disease, because this will allow me to decide if my patient needs a further treatment after chemo, for example, a stem cell transplant, or whether chemo is all that is required. And I also look and confirm to myself as to what is the evidence behind all of these treatments. Now, prognosis of different type of lymphoma is extremely important for us to plan therapy. And please don't be bogged by the details of this diagram, but I'm going to get you through this picture. So the yellow line represents the outcome of patients with anaplastic large cell lymphoma, ALK positive. The blue line is also anaplastic large cell lymphoma, but ALK negative. The peripheral T cell lymphoma, it is denoted by the red color. So what this diagram is showing you is that the ALK positive ALCL has the best outcome out of all the different subtypes. So perhaps for those patients, we may not need to use other aggressive therapies like transplant, but for the other subtypes, perhaps we may need to. So prognosis is very important for me to plan treatments. So let's now focus our objectives to learn about different type of treatment T-cell lymphoma, especially the extranodal and nodal ones. I will talk about cutaneous T-cell lymphoma a little bit briefly at the end of this presentation. So the therapy of extranodal and nodal T-cell lymphomas are fortunately similar. This is because T-cell lymphoma is quite rare, so we do not have that much evidence onto treating a big group of same kind of lymphoma, for example. So all T-cell lymphomas are treated similarly, except for the extranodal NK/T cell lymphoma. And what we kind of know from my previous slide is that ALCL, ALK positive, have really good outcomes. So for those patients, chemotherapy that is required. But for all other patients, after the initial chemotherapy, we do consider autologous stem cell transplant, which is where we harvest stem cells from the patients themselves and then give it back to the patient after giving them more aggressive therapy after their initial chemo. Now, there are three most common type of chemo cocktail that we use in patients with T-cell lymphomas, and these are CHOP or CHOP. The other commonly used is CHOEP or CHOEP, and last one that we have started using more recently is CHP plus brentuximab vedotin, or CHP plus BV. And each letter stands for a different chemotherapeutic, but when we combine these agents, it does produce synergistic effect. Now, let's look at where the evidence behind CHOP came from. Now, in the past, we didn't have a good way of distinguishing between B and T cells. So B and T cell lymphomas were all classified together, and they were also treated very similar. And the older classification looked like this. So older studies of aggressive lymphomas included both B and T cell lymphomas. Now, this older study that was published way back in 1993 took all patients with aggressive lymphomas and divided them into 4 groups. One group got CHOP, the second group got another cocktail called MBACOD, and the third group got PROMACE, and the fourth group got MACOP-B. And as you can see from these curves are all the same. What it meant is that CHOP and other aggressive regimen had similar outcome. However, what we found is that the toxicity from CHOP was significantly less compared to the other regimens. So since 1990s, CHOP was the treatment that we would give for both B cells as well as T cell lymphoma. However, as time went by, we started learning that patients with T cell lymphoma, they did not have a good outcome as those with B cell lymphomas. So we knew that the outcome of patients with peripheral T cell lymphomas were inferior to the B cell ones. And we were further able to divide the peripheral T cell lymphoma into ALCL subtype and non-ALCL type. So as again, you can see that the ALCL subtype had a better outcome compared to the ones that were not ALCL. And our learning just did not stop there. We then started noticing that patients who had ALCL ALK negative, they also had some subgrouping. So for example, the patients with ALCL ALK negative, they had recurrent translocation of this gene called DUSP22 or DUSP22, as well as TP63. And what that informed us is that if we were to take patients with ALK positive ALCL, the outcomes were really good, similar to those of B cell lymphoma. But those with ALCL ALK negative, they had quite inferior outcome. However, if you took the ALCL ALK negative and divided them into the DUSP22 or the TP63, you can easily see that those who had DUSP22 rearrangements, they did as well as those who had the ALK positive. So this kind of information helps us really tailor our treatment of patients with T cell lymphoma. So again, we know that CHOP did not produce as good outcome in patients with T cell lymphoma like it did in patients with B cell lymphoma. So there have been a lot of efforts going on for the last several years to try and better the CHOP chemotherapy backbone. So this study that was published in 2010 looked at the effect of adding etoposide to CHOP-like backbone. So what they did is they took a few of their clinical trials where half of the patients got CHOP and half of the patient got CHOP, which is CHOP plus etoposide or similar agents. And what they found is that when they took all these patients, the ones who got CHOEP or the one with the etoposide, they had better outcome compared to those who did not get etoposide. And these are 2 different trials which both showed that adding etoposide was beneficial. And then this group is only patients with ALCL ALK positive who tend to do better anyways. But even in that group, adding etoposide produced much better results than not adding etoposide. And these group are all the other ones. So these are the ALK negative, AITL, PTCL, NOS, etc. So as you can see, addition of etoposide did add to some benefit, but all of these trials included patients who were younger than 60, and LDH, which is a parameter we measure in our blood that shows us how aggressive a disease could be, had to be normal. So what we started doing after this study is that anybody who was younger than 60 and with normal LDH, we would add etoposide to CHOP. Now, we have looked into adding other agents to CHOP and see if it can improve the outcome. So this column here just tells us about the author of that study, and this column tells us how many patients were included in that study. And as you can see, a lot of investigators have tried to add different agents to CHOP. So this looked at adding bleomycin, this looked at adding alemtuzumab, and this looked at adding bortezomib. Now, this is the complete response rate, and this is partial response rate. And as you can see, there is not that much significant difference by adding any of the agents. So unfortunately, we didn't find anything that was that significantly better than CHOP or CHOEP. We have also tried doing other interventions where we completely changed the initial chemotherapy that we give to patients with T cell lymphoma. So for example, this trial compared CHOP with another chemo cocktail that we call VIP-R-ABVD. And as you can see, the outcomes were not that different from each other. There was another clinical trial that compared CHOP with another agent called GEM-P. And again, they were not significantly different outcomes. So whether we changed the upfront chemotherapy, it looked like there was nothing that was doing a better job than what CHOP was doing or CHOEP was doing. What is important for the audience to also know is look at the size of the studies. These studies are very, very small. And in order for us to see good evidence, we like to have sample size that is large. But the reason why these studies have only fewer patients is because T cell lymphoma is very rare. So for them to be able to find a large cohort of population is not that easy. Now, we talked about adding drugs to CHOP. We talked about comparing CHOP with a completely different induction regimen. There have also been studies where they have given CHOP but alternating with other agents. And again, that also did not improve the outcome of patients with T cell lymphoma as much as we would like. However, recently we have made some big strides, at least in some subgroup of patients. So this is one of our newer trial called Echelon 2 trial. And what it did, it compared CHOP to CHP, which is the same agents as CHP here, but we took out the O or oncovincristine and substituted it with brentuximab vedotin. So brentuximab vedotin is a new drug, and what it is a monoclonal antibody, and it targets this marker on your T cells that we call CD30. So brentuximab vedotin will only work well in patients who have CD30 antigen on their surface. And what we found from this study is that the arm that received brentuximab had significantly better outcomes compared to the arm that got CHOP. It not only improved time to progression, but it also showed that there might be a benefit in terms of overall survival. So as of last year, for patients who have advanced stage disease with CD30 positivity, we have changed our practice and have been giving them CHP plus brentuximab. Now, those are just some upfront therapies, and I had already talked about trying to provide additional aggressive treatments to improve the outcome of patients. So we do consider stem cell transplant in patients who have received upfront chemotherapy and have attained what we call a complete response or a partial response. So these, again, is just the couple of studies that looked at what was the benefit of adding a transplant. So for example, this group gave CHOEP first, followed by transplant. So, this group gave mega CHOP, followed by transplant, etc. So bottom line is patients got some form of initial chemotherapy, followed by an autologous stem cell transplant. And as you can see, about 70% of those patients were able to go to transplant. And if you look at their 5-year or even 3-year overall survival, it was similar to the group that did not get the transplant. So even though we do recommend transplant after initial chemotherapy, we do not know exactly if there is too much of a benefit by adding the transplant. And especially now that we have agents like brentuximab, we don't know if a transplant is really necessary. Now, there have been some studies that have looked to see if adding a transplant is really beneficial, but most of these studies are retrospective, meaning they were not randomized prospectively. So, for example, this group identified about 270 patients who were intended to get a transplant and who were not planned to get a transplant. And what they found is that they had about 134 patients where the transplant was planned and 135 patients where no transplant were planned. And then they looked at the outcome of these patients, especially the ones who got transplant, and they found that there was no difference in outcome between patients who got transplant and who did not get transplant, even though by age and other parameters, they would have qualified for transplant. The only group that seemed to benefit from a transplant was the group that got a partial response. So again, these are just food for thoughts. We haven't changed our practice yet, but we do now understand that there might not be that much benefit from adding transplant, but again, that still needs to be proven. So up until that gets proven quite well, I think we would still feel much more comfortable offering transplant to patients who are able to, so that we can provide a deeper response at least. Now, there have been some studies where they have given allogeneic stem cell transplant, where we have given transplant from a donor to the patients. But again, there hasn't been that much significantly different outcomes. So that is also kind of experimental at this point. So in summary, for the nodal or extranodal T cell lymphoma, CHOP is considered for most patients who are over the age of 60 or have an abnormal LDH. For those patients who are younger than 60 but have normal LDH, we may consider adding etoposide, again, depending on the functional state of that patient, etc. For those patients who have CD30 molecule, we give CHP plus brentuximab. And for every patient except for those who are ALCL positive, we do consider post-chemotherapy consolidation with stem cell transplant. Now, remember I had mentioned that patients with extranodal NK/T cell lymphoma are treated slightly differently. Now, this entity is extremely rare, so it is very hard to include these patients in the clinical trials that I previously discussed. And this entity usually involves the nasopharyngeal area, and it is associated with EBV infection. And the management, again, depends on whether it is localized, meaning limited stage, where we give chemo and radiation, or if it is an advanced stage, where we give chemo plus or minus stem cell transplant. Now, note that I've written chemo because the standard is still not clear. So different countries have different ways of approaching these patients. So please, again, don't be overwhelmed by this list. These are just names of investigators that treated this entity. This is the country where the evidence comes from. And again, you can see just a very small group of patients. And the treatment that they received was chemo plus or minus radiation, depending on the stage. And if you look at the chemo, some group did give CHOP, but more recently we are not giving CHOP. We are giving agents like VIPD or DEVIC or GLOX, etc. if it is just a limited stage disease. If it is advanced stage disease, we use these chemo cocktails called SMILE. So each letter kind of stands for a different agent. So that kind of takes me to what do we do after the initial treatments fail, or what do we do when disease relapse? So at relapse, we often use salvage chemotherapy. So salvage chemotherapy means chemotherapy that they may have not received previously. So commonly used agents in people with T cell lymphoma are agents like ICE, or things like GDP. So these are, again, different chemo agents. And if they did not get a transplant, then we consider taking them to transplant at that point. And if they are not candidates for salvage chemotherapy, then we use novel or newer agents. And we also look to see if we have clinical trials available for which we can enroll our patients. So I will briefly talk about some agents that we frequently consider for patients with relapse refractory T cells. So there is an agent called pralatrexate. What it does, it inhibits this enzyme called dihydrofolate reductase, and in doing so, it interferes with the DNA synthesis and helps kill the cancer. So this chart here on pralatrexate shows that there was some studies where they included these many patients, and these are some of the response rates that were reported for different types of T cell lymphoma. And as you can see here, the outcomes are still not that good. I mean, for those who respond, their median duration of response is about 10 months, but the average time from starting treatment to perhaps recurrence is about 3 months. So even though the drug is available, it may not be associated with robust outcomes. Other agent that we commonly use in the relapse setting is agents like romidepsin, which we call it as an HDAC inhibitor. And again, it interferes with DNA synthesis, and hence it may affect cancer cells. So again, if you look at this box here, so these are a couple of studies that looked at giving romidepsin to patients with T cell lymphoma when they relapsed. And the response rates were dependent on what type of T cell lymphoma it was. But again, if you look at some studies which demonstrated a median duration of response of it about 28 months for those people who responded. But again, the average time to recur was not that good. There are other agents, like we talked about brentuximab vedotin. So before we brought it to treat patients with T cell lymphoma in the upfront setting, it was actually being investigated in a relapse setting. And again, patients with ALCL had really good response rate to brentuximab, which is not surprising because ALCL does have CD30 expression. And the progression-free survival was better, especially in the ALCL group. So we do use brentuximab in patients who did not get exposed to brentuximab, and if their pathology does demonstrate CD30 molecule. Then, just like romidepsin, we have another HDAC inhibitor called belinostat. And again, if you look at the numbers of response rate as well as median time to recur, it is not that robust. So similar to other agents, we do have a lot more drugs, and I don't want to go through each and every one because that information is still very overwhelming. But the bottom line is, yes, there are some drugs available, but they do not work that well. So at the moment, we use an algorithm like we talked about. So we use CHOP, and if they fail CHOP, we go to salvage plus transplant. If they are not candidates, then we try to see which of these drugs might be available and approved in Canada for T Cell lymphoma, and we go from one line to another. Also, we consider clinical trials if they're available, but if none of that work, then the outcome becomes very poor, unfortunately. So you may have already guessed that we have mountains to climb when it comes to improving the outcomes of T Cell lymphoma. Obviously, things have improved with the introduction of agents like brentuximab, but there's still a lot of work that needs to be done in order to improve the outcome of our patients. There are a lot of clinical trials accruing, looking at newer therapies. So hopefully in 5 years from now, we might have better treatments for T Cell lymphoma. So we'll just have to keep an eye out for new developments. Now, I'm now going to shift the gears, and I'm going to go to the treatment of cutaneous T-cell lymphoma. And cutaneous T-cell lymphomas are treated completely differently than the nodal or extranodal subtypes, because skin lymphomas can present in a variety of ways, as you saw from my previous staging diagram. They could present with one lesion in the body, they can present with multiple lesions, or they can have head-to-toe involvement. And based on all of that, we decide upon different treatments. So for example, sometimes people present with lesions and they may not have any symptoms. So for those people, we may decide to just wait and watch, because if it's not bothering, then we shouldn't be treating. If they are being bothered by, say, itching or things like that, then we do consider steroids topically, which are steroid creams to alleviate their symptoms. If that doesn't help, then we can consider agents like nitrogen mustard, which is not easily available, or perhaps even local radiation to that one lesion. There are agents like retinoids, which we use, and sometimes we also use things like ultraviolet light, which has shown some improvement in these lesions. And a lot of other treatments are available, but unfortunately, none of these treatments work that well. And again, we do now have entities of mycosis fungoides or even cutaneous T-cell lymphoma, which are CD30 positive. And for those, we can consider brentuximab if they have been trialed with a few lines of treatment without any response. So this is kind of management of cutaneous T-cell lymphomas in a nutshell. So in concluding remarks, we discussed that T-cell lymphoma is quite rare. The most common types are the nodal and extranodal, especially the peripheral T-cell lymphoma, the ALCL, and the AITL. So those patients are treated with either CHOP if they are older and they do not have CD30 molecule, or CHOEP if they are younger and have normal LDH, or CHP plus brentuximab if they are CD30 positive. We then consider transplant for most patients except for ALCL, noting, of course, that the benefit of adding transplant to patients with T-cell lymphoma is still not completely clear. And we also learned that the treatment of NK/T-cell and cutaneous T-cell lymphoma is different. And I also mentioned that efforts to improve outcome of patients with T-cell lymphoma continues. So with that, I will conclude my presentation, and please feel free to ask me any questions.
Thank you very much, Dr. Kansara. We really appreciate that excellent presentation on T-cell lymphomas and appreciate your excellent review of this lymphoma subtype, highlighting the major classifications within the subtype and discussing the Canadian-specific therapies available for this patient population. I would now like to direct our audience to please go ahead and attend the breakout session on non-Hodgkin lymphoma, which will be starting at 3:30 p.m. EST, to then have your questions answered by a live panel of hematologists and oncologists, including Dr. Kansara. I wanted to say thank you again to Dr. Kansara for putting together this excellent presentation, and thank you very much to our live audience for attending. Thank you and goodbye.